Oh, thank you so much, everybody, for joining us. Thank you, Dr. Saxena, for agreeing to offer a presentation to our wonderful community. Dr. Saxena is one of our hip and knee surgeons here at Rothman Orthopedics. He sees patients in our Hamilton, Pennington, Princeton, and Newtown, Pennsylvania offices. He has got a excuse me, sorry, I'm not feeling well. He has been with Rothman for many years and has lots of experience, and I will let him get started. Just one quick housekeeping thing. This is being recorded, so if you have to hop off for any reason, it will be emailed to you within the next week. And we do have a kind of hard stop a few minutes after 6, so we'll get through the presentation as many questions as possible. If you have any other additional questions, you can always email me. Everybody has my email and my phone number, and I will turn it over to you.
Thanks so much, Kristen. Really appreciate the opportunity here. It's a great opportunity for us as surgeons to kind of talk and educate our community about, health conditions, because it just makes you that much more prepared if you're dealing with something or if you're in the office, and kind of gets you to those next level questions. And when we talk about hip and knee replacement, there's a lot of planning that has to happen. So the more you know, kind of going into the office, the kind of better prepared you are. So without further ado, we'll get started. So we're going to talk about hip and knee arthritis and joint replacement surgery. And a lot of people are going home after these surgeries, so we'll talk about that as well. So we'll start out with the hip. This is an example of an arthritic hip. And so how does the hip work? Well, you have this ball and socket joint. So here's your femur or your thigh bone. And then there's the top part of the thigh bone is a ball called the femoral head. And that articulates with a socket as the pelvis. And that socket and the head are covered with cartilage, which is a very smooth surface that allows things to move on each other or against each other without really any friction. And what arthritis is the loss of cartilage. So it's the most common cause of pain in the United States. Arthritis is basically wear and tear, and that cushion that allows for smooth motion in the joint deteriorates. It's a degenerative condition, usually gets worse over time, not better. There's also a host of other diseases, autoimmune diseases like rheumatoid arthritis, that can actually have cells of the body be attacked, or cells of the body attack the cartilage, and that causes swelling and degeneration, just like arthritis. So arthritis can be developed from abnormal anatomy. And an example of this is, if you're born with an abnormal hip joint as a child, you're predisposed to developing arthritis when you're 50 or 40 years old. Abnormal biology. If you have a lack of blood flow to the joint, that can cause a condition known as avascular necrosis. Bo Jackson got that after the traumatic hip dislocation in the famous Monday Night Football game. That can lead to a hip replacement. It can also cause problems with the knee as well. Overuse, could you just be someone who was active your whole life and just kind of wore out the joint? And then genetics. What we find a lot of times is we'll tell patients, oh yeah, you have arthritis, you may eventually need a hip replacement. Say, oh, my brother got one 2 years ago. And so we hear that, or my grandmother, she had bad knees and she had knee replacement before she passed. So these are a lot of things we hear from patients too. So again, what causes pain? It's, the end of each bone is covered with cartilage, that smooth surface that has a very low, what we call coefficient of friction. So the joint functions and moves very smoothly. The diseased hip loses cartilage, and that deteriorates that natural cushion and then causes more friction at the joint. So my best analogy is a normal functioning joint is a door hinge. This is a brand new door hinge in a brand new building. It's analogous to healthy cartilage. It's well lubricated. It's got full motion, and it's pain-free. And then you take for granted all the things that you do normally in life: walking, getting in and out of a car, exercising, sleeping, not having pain on a daily basis, and just enjoying life. Well, over a lifetime, 30, 40, 60, 90 years, this is what that door hinge becomes like, right? This is a damaged cartilage. There's loss of the lubricating mechanism. There's loss of motion, and there's more pain. So when we talk about hip arthritis, we'll ask people, well, how bad is it? How much does it affect you? Do you limp? Do you have difficulty performing normal activities? Most commonly with hip, they're going to have difficulty putting on socks and shoes or tying shoes. Is there any limit to your activity or lifestyle due to the hip? Does one leg feel shorter? Do you have balance problems? Where do you have pain? It could be in the thigh, the groin, or even the butt. Does the pain radiate down to the knee? That's also pretty common in hip arthritis. When we're talking about diagnosing hip arthritis, usually all you need is an X-ray. You don't need an MRI or a CT scan most of the time. It can be treated non-surgically as well. Water therapy with soaking or hot packs or ice, exercise and physical therapy, believe it or not, are good for an arthritic hip joint, and also good for weight loss, which is going to help an hip joint as well. Medications, anti-inflammatories, Motrin, Tylenol, things like that, and then injections like steroids can be placed into the hip joint. And when these things fail, a hip replacement is the next option. The hip replacement is a great procedure in that it replaces the damaged surfaces, helps relieve pain and improve mobility, pretty common in the United States at this point. So we could go back to the beginning of the talk, and here you have this picture of what a normal hip joint looks like. And here's what what a replaced hip joint looks like. So what we do in a replacement is we cut the bone right about here, okay, right about here on this picture, and we take this bone and we throw it away. And then what we do is we put a metal shell in the pelvis, a metal stem inside the femur, so patients can't feel these. And then we put a ball and a liner to articulate it. And that hopefully recreates your natural hip joint and lets you to walk and move without pain. So here's an example on an X-ray. Here's an arthritic hip joint. It's bone rubbing on bone right there. There's some cystic changes in the femoral head here. There's some hardening or sclerosis of the bone here. And now what we did in this surgery, we cut the femoral neck right about here, took this bone, threw it away. Now there's a metal stem inside the femur, a metal shell in the pelvis, and then a ball and a liner articulate to complete the hip joint. One thing that I do is I use an anterior approach to the hip joint in a number of my cases. I think it's a nice way to do a hip replacement. In a traditional surgery, a lot of times patients will lie on their side and they'll have a scar on their side or go to their buttock. In this surgery, you lie flat on your back on this torture table. Don't worry, you're under anesthesia, you can't feel this. But basically, we use this table to manipulate the leg so we can perform the surgery. We can get into the hip joint without cutting any major muscles or tendons. And I think that probably leads to a slightly improved recovery. But believe it or not, there's 4 major approaches to the hip joint. There's actually really no difference in outcomes no matter what approach you have. So I actually recommend people, find a surgeon they're comfortable with and just let that surgeon do what they do. Hip replacement's a very common procedure and also a very successful procedure. Most patients say that, if they had the procedure that they would do it again. Most patients also tell us they wish they'd have done it sooner. So in summary on hips, the leading cause of hip pain is arthritis. It's a degenerative condition that won't get better over time and might get worse. And early diagnosis and treatment are important, so you can use the non-operative treatment methods. And then once those fail, hip replacement's a great way to relieve pain and improve mobility. The knee is actually more common than the hip. And the knee is a pretty complex joint. People think it's just this hinge where the tibia moves back and the femur stays still, but it's actually a pretty complex joint with a lot of degrees of motion in it. So, but similar to the hip, you have 2 main bones, the femur, the thigh, and the shin or the tibia. The patella is also in there too. And then the ends of those bones are lined with cartilage. And then as the cartilage breaks down, the articulation has more friction and can cause more pain and dysfunction. So again, arthritis is one of the most common causes of knee pain. The rheumatoid or inflammatory arthritis also cause knee pain. So again, here's another picture with the healthy knee has normal cartilage, but this one you can see the gray cartilage is damaged here and here and here. And that's going to cause abnormal motion in the joint. That's going to cause pain and swelling. Here's an example of a normal knee with black space in between the tibia and the femur, and that's pretty good. Here's an example of an arthritic knee with the bones touching each other right there. So there is no space for the cartilage on the X-ray right here on this one. So when we ask people about their knee pain, we ask, okay, well, does it hurt often? Does it interfere with sleep? Is it hard to walk more than a block? Do medications not help? Has inactivity from knee pain caused you to gain weight? That's a really concerning one. So these are all things we ask to find out, how much does an arthritic knee really affect a patient adversely? Treatment for non-operative methods is pretty similar to the hip. Water, ice soaking, ice, hot packs, exercise and physical therapy, again, very good for weight loss. Medications, anti-inflammatories and steroids can help. Injections, steroid injections can help, but also the knee has hyaluronic or viscosupplementation injections. Lots of brand names out there: Hymovis, Orthovisc, Synvisc. They all do the same thing. And what they're trying to do is mimic healthy joint fluid to create more lubrication in the joint and to decrease inflammation. Just so you know, those injections, the visco injections or the gel injections, they're not gels that stay in the knee joint and actually spread the bones apart. They're actually gone from your joint in about 48 to 72 hours. So they're really more of a medication and not a gel that's going to increase space in the joint. Knee replacement, again, once the conservative treatment options fail, this is a great procedure, very common in the United States. Here's an example of a knee replacement. So what we do in a knee replacement is we remove a thin portion of diseased bone and cartilage off of the end of the femur and the top of the tibia, and we replace those pieces of bone with metal and plastic. So a metal piece on the femur, metal piece on the tibia, piece of plastic in between. Here's what it looks like on the X-ray. You have a white piece of metal here on the femur, white piece of metal here in the tibia, and then a plastic piece right in between them. We also oftentimes will do a plastic piece on the underside of the kneecap, but you keep your own kneecap after a knee replacement. So example of a healthy knee with space between the bones, an example of a joint replaced knee where this plastic kind of mimics the cartilage on the X-ray. So in summary, the leading cause of knee pain is osteoarthritis, a degenerative condition that won't get better and will likely get worse over time. Early diagnosis and treatment is really important, and knee replacement is a very successful operation as well. I'll be honest, if you talk to patients who've had a hip and a knee replacement, they'll all tell you the hip replacement's easier. The knee replacement is a tougher surgery, takes a little longer to recover, but it really can make a huge difference in someone's life, which is really gratifying when you see that. So, for your parents or on the age ranges of the people on this call, but if you have parents, they may have had hip or knee replacement in the 1990s or early 2000s, and they may have been used to, friends or family members or even themselves staying in the hospital for 3, 4 nights, going to a rehab facility for a month, and then finally going home. Don't expect that anymore. This is totally different. This is not your grandmother's hip replacement or knee replacement anymore. So for the hospital stay, most people will either leave the day of surgery or the day after. The recovery, we really accelerate it. We have programs called rapid recovery where patients get up with physical therapy, usually within 3 to 4 hours of surgery. We have a lot of things we do to control pain and nausea. And if you can do that, then I think it enables and allows people to kind of do their rehab faster. And physical therapists are key partners in this. And the other big thing too is what about returning to work? A lot of younger people are getting these done as we're diagnosing it earlier in a lot of people. And so, it's tough. Depending on your job, you may be able to get back to work. I had a patient tell me he was back in a week, but somebody with a more physical job might take 3, 4 months. So it's kind of all dependent on the patient and their job and their support system. So outpatient joint replacement means truly outpatient, like having the surgery and going home the same day. It's kind of been, the length of stay has been going down over the last, 2 decades. But really, I think COVID kind of catapulted this because people realized they didn't want to be in the hospital. Actually, they weren't allowed to be in the hospital during COVID, but they could get their surgery if they came and left. So it's much more common now than it used to be. I'd say our practice is probably about 40% of patients. We do about 17,000 joint replacements a year. 40% of those people will go home the same day. And the key with outpatient joint replacement and the key with success there is, are you a candidate? You want to make sure the patients have the best opportunity for success. So if someone has, a lot of medical problems, not a lot of support at home, that may be a bad candidate for outpatient joint surgery. So there's some keys to this, and we've developed a lot of protocols. We operate at a lot of facilities at Rothman, surgery centers, hospitals, specialty hospitals. So a real big key is patient education, and part of that is expectations. What can I expect when I go home the day of surgery or the week of surgery? Patient selection, like I said, is really key. We want low-risk patients. We want, controlled diabetics. We don't want, morbidly obese patients. We want them to not be nicotine users. We don't want them to be anemic before surgery. So these are all things we check before surgery to make sure someone's safe for an outpatient procedure. Infection prevention is huge. The goal here really is to provide the same service, the same product as you would in a hospital. So the same infection prevention precautions are all there. People have to do like wipes in the shower the days before surgery. We do nasal swabs when they get to the hospital to decrease the MRSA infections in certain patients, and then same room instrument cleaning. That's all the same between a hospital and a surgery center. All that stuff's the same. So really, it should be the same procedure, whether it's at a hospital or a surgery center. It's really important that patients get prepared. There's mental preparation, kind of being prepared to, have pain, to have dysfunction. How are you going to deal with that? It's really helpful for a patient to have a caregiver or a quote unquote coach to kind of push them, make sure they're doing what they're supposed to do, kind of go through the instructions with them and make sure everything's going in the right direction. My goal for my patients is for like me to see them the day of surgery and them to say, "Oh, I don't have any questions." Because we went over everything. And so that's really the key for my education. I create actually, most of our doctors at Rothman create like a personalized packet for each patient, kind of answering all the questions or going over all the things that the doctors think are important. And a lot of us, just with our experience, know what's important to patients as well. So we focus on those things. I think the biggest key with whether it's surgery going home the same day or even just surgery in general is the fear of the unknown. Is it going to hurt? Am I going to be in so much pain that I can't function? How dependent am I going to be on others? You may be the family member that everyone else depends on. So how are they going to function if you're getting a knee or hip replacement? What about driving? I mean, we want to be able to get back to work. A lot of people think 2 weeks is a reasonable time to get back to driving, and I think that's an individual answer. Every person might have a little different threshold, especially once they're going through the recovery. What about back to work? Same thing as I mentioned before. Could be pretty quick depending on your job. Could be 3, 4 months depending on your job. And when will I feel normal? That's a big question, and that's part of kind of following patients through this process of surgery. But it takes a while. It can take 6, 12 months for this surgery to kind of fully get a full recovery. So these surgeries are big surgeries. It's definitely a process. It's not something like, oh, I'm going to get my knee done next week, and then in 3 weeks we're going to Europe for the month. That is not how I would approach this. This is a big deal, and it is a tough recovery. Outpatient joint replacement, one of the reasons it works is because we do what's called multimodal analgesia. So, everyone's heard about this opioid epidemic. By using different types of medications with different points on the pain pathway, we're actually able to decrease the amount of narcotics we use and decrease the prescriptions we give. So that's really helpful in kind of enabling people to go home. Narcotics have complications. They can make you drowsy. They can make you constipated. If we're using medicines other than narcotics to help with pain, we can avoid some of those. And that's really helpful, especially for people going home the same day. Really important that your program that you go to for an outpatient joint works as a team. So it's going to be the nurses before surgery. It's going to be the anesthesiologist you meet the day of surgery. Also the physical therapists. That you may see them in the facility. You may see them as an outpatient. Usually for hips, we actually don't send them to formal physical therapy, but many knee replacements will go to formal physical therapy. Sometimes pre-op therapy is helpful, so you can kind of understand what's going to be expected of you and just be more prepared. What about equipment? Are you going to need a walker, a raised toilet seat, a cane, etc.? You want to plan ahead on that. Most insurance companies will provide a walker or a commode, but most other things are going to be cash pay. So it's important to plan ahead and get those ahead of time, as opposed to trying to get them on your way home from the facility. And then steps. That's a big question people have. I have steps at home. How am I going to function? And I say, perfect. I want you to go up and down as many times as you can. That's part of your therapy. The first couple of days, it may only be once or twice a day, but hopefully as time goes on, you're doing the steps more and more. Additionally, oftentimes a physical therapist will have a set of practice steps available to them. So, whether you're in an ASC or a specialty hospital or a regular hospital, there'll be an opportunity to practice going up and down steps before you leave the facility. And so people always ask in these talks, how do I prevent a joint replacement? The number one thing is to stay active. Sedentary lifestyle is really just a killer for all of us. So really important to not be a couch potato. Stay active, even if it's just a walking program every day with a friend or a neighbor or a spouse. That's really helpful. Weight control also very helpful. Complications rise as your weight goes up. And so that can cause complications in the time of surgery, but also the more you weigh, the more force going through the joints and the faster you'll wear them out. So there's studies from England looking at populations that in like regions of England where people never leave. And they actually found that if in your 20s, you're just 10 or 15 pounds overweight, you're like 3 times more likely to end up with a knee replacement. So that weight control is really important kind of throughout your life. That was kind of all I had for you today. Happy to take any questions you may have, and we can go into more detail based on the questions you have. But that's sort of the rundown of kind of hip and knee replacement and where we are today and how people are recovering.
Great. There's a few questions, and if anybody has any additional questions, you can put them in the Q&A box. There's a couple there. Partial versus full knee replacements, benefits and downsides of a partial.
Yep. A partial knee replacement is like my favorite surgery. It's just a really elegant surgery, and I really like it. Um, the key is indications. You want to make sure that you're giving the right patient the right surgery. And so usually we use just X-rays. Sometimes an MRI will be helpful to determine if someone just has knee arthritis in one part of their knee. There are three major compartments to the knee: the inside or medial, the outside or lateral, and the part between the patella and the femur. Um, and if you have isolated arthritis in one of those compartments, you could be a candidate for a partial knee replacement. Next question is about the Jiffy method for surgery compared to standard approach. It's mostly marketing, but just like the hips, there's like different approaches. The knee also has a couple of different methods to getting into the knee joint, and they all work. None has been proven to be better than another. So again, it's really important just to pick a surgeon that you're comfortable with. Maybe your friend had surgery by them, or a coworker, or you met them and you felt comfortable being able to talk to them and ask questions of them, and let them do kind of the procedure that they do. Recent Washington Post article about knee denervation, radiofrequency ablation, and genicular artery embolization. Are those procedures performed at Rothman? Have you had any success with these? Yeah, these are all new techniques in the pain management world to try to decrease pain. The kind of thought process is by decreasing the nerve impulses that go back to the central nervous system, we may be able to decrease pain. I think the jury's kind of still out on some of this stuff. There's definitely some data that shows they can help, but unfortunately, they don't seem to provide long-lasting evidence. So what I've seen, we don't we do some of our doctors perform these procedures at Rothman, but not in every office. So in my office, nobody really does them. So what I do is I send them to a doctor in the community. And some patients say it didn't work at all. Some patients will say, well, I got 6 months and I felt pretty good, but then it kind of started coming back. So they're good procedures, and we probably need better evidence to kind of truly assess who they're going to be most effective in. But they can certainly work, and certainly something to look into. Next question is, how do you size for the prosthetic? That's pretty easy. We kind of have templates in surgery that we use to kind of basically see what template fits on that patient's femur or tibia, and that's how we size. There are some other advanced techniques using artificial intelligence or CT or MRI scanning or robotics that also work as well, and I have experience with those as well. None have been proven to be better than another. Um, this was supposed to be minimally invasive focus. I didn't know that it was. Minimally invasive surgery is really kind of, I would say, more of a marketing term. I think we want to be as minimally invasive to the tissues as we can be to patients, but there's no real true definition of what's minimally invasive and what's not. So when that kind of fad came out about 15 or 20 years ago, I think the real benefit it brought to orthopedics and surgery in general was that we really want to take care of how we handle patients' tissues, as far as with retractors, as far as with anesthesia, like local anesthetics or nerve blocks. So kind of my take on minimally invasive. Cosamine chondroitin, does it help your joints? It certainly can. Chondroitin or hyaluronic acid are the building blocks of cartilage. So there's some that think, oh, well, if that builds cartilage, I should just eat those supplements and then have more cartilage. Doesn't really work like that, but those supplements we see that they seem to have an anti-inflammatory effect. So they could certainly help. So I always tell patients, look, try it, see if it works for you. And if it doesn't, then stop using it. What determines whether you can knee on the knee? I assume that's kneel. I usually think it's time. Usually at about the 4-month mark, I'll give patients a desensitization protocol to kneel on the knee. But yeah, you're not going to cause damage to your knee by kneeling it, but it can be certainly irritable because the bottom part of that incision is kind of right on the bone there. Is there a danger to getting a knee replacement too early? Meaning, would you need a second later in your life? Is there an ideal range? Yeah, that's tough. If you're looking at a 45-year-old and they have bone-on-bone arthritis and a ton of dysfunction and pain, it's hard to say, hey, maybe wait till you're 65 so that you might never need another surgery again. So that's 20 years of someone's life they could live with pain and suffering. So I don't really I don't know that there's a danger of doing it too early. I think people need to have the appropriate expectations and understanding of the consequences of doing it, at a younger age. But at the end of the day, it comes down to quality of life. And if you're 45 and you can't, walk around or do a hike with your kids because your knee hurts and it gets swollen up too much fast, a knee replacement could significantly improve that quality of life. So I would say go for it to that patient. And Look, it sounds terrible, but you get hit by a bus at 58 and never have to worry about that second surgery, right? Or maybe it'll last you 25 or 30 years. You'll get another surgery at that point when you're 65 or 75 years old, and you'll move on. But I think what we see now in our patients is they're really living for like the now. So yeah, I don't ever think it's too early. I just think that people need to go in with the appropriate expectations. How is a revision different from original knee replacement? Well, revision is a procedure that you do when a knee replacement has failed for any number of reasons. And so revisions are harder. It's harder to go back into the joint a second time for the surgeon, harder for the patient to do the rehab. And they can range from being super simple, like yesterday I did one where I just changed out a piece of plastic and closed it up. It took a half hour. But sometimes you're, chiseling implants out of bones, chiseling cement away from a bone, putting in these, huge reconstructive implants. So they can be pretty complex. What medication that can be used for someone who can't take NSAIDs because of a blood thinner? Yeah, this is a tough thing for patients to undergo if you can't use anti-inflammatories, because those medications are just so helpful in controlling pain. So unfortunately, patients with blood thinners typically can't take an NSAID. And so you're kind of limited to Tylenol before and after surgery, which in my experience is not as effective. But yeah, you're at a disadvantage for sure. I got a question. Can a replacement, hold on a sec, maybe I went the wrong way. Oh, no, I didn't. How effective is Synvisc and how long does it last? Synvisc is one of those gel injections, viscosupplementation. I've seen people get, 6 months to 1 or 2 years out of it. I've also seen patients get like zero relief. So it's really just a question of how patients respond. Typically, patients with more mild arthritis do better with it. What about knee replacement for an older person, a 90-year-old who's healthy? Yeah, the problem with operating on 90-year-olds is that complications happen. As you get older, 85, 87, 90, the rate of complications after surgery just skyrockets. So that's really the problem. Sometimes you'll get a really healthy 90-year-old. And again, as long as the patient and the family understand the expectations and understand the potential consequences, it's okay to proceed with surgery. Are PRP shots a legitimate alternative? Yes, they are. We just don't have a ton of data on them, so we don't know. And there isn't a ton of standardization, so they haven't been approved by insurance. So typically they're a cash pay option, but they certainly can help. There's certainly an anti-inflammatory effect from those platelets that come from your own blood. The question is, are they going to change the outcome? Probably not. They're not going to make it so you don't need a knee replacement. They're not going to regrow cartilage. So it's a good alternative treatment option, but it's probably not going to change the outcome of your knee long term. Can a knee replacement fix a knock knee condition? Yes. So most knees that are arthritic are in a varus or bow-legged shape, I guess. But sometimes, about 10% of the time, you can get knock-kneed or valgus alignment, and that can be corrected in surgery. What about titanium? Titanium is a great metal, and a lot of times we use that on our implants, especially in our knee and hip replacements. Next, is physical therapy recommended to relieve pain without surgery, or is exercise on one's own better? Yeah, either works, right? Physical therapy is super important. And here's my thing with physical therapy. It's really important. The biggest part of physical therapy is not that you just do it when you go see your therapist. You have to do it every day on your own. So physical therapy is a very helpful thing before surgery to help someone get ready for surgery, especially in a knee replacement. Very helpful after a knee replacement to help someone get their range of motion and strength back. But it's certainly something that you do on your own as well. So the answer is kind of yes to both of those. A wife is getting gel injections at Rothman. We thought it would be helpful longer than what you said. Well, it could be. I mean, it may not work at all for your wife, but it could work 6 months. It could work a year. It could work 3 years. I actually had a patient today who I did gel injections in 2021. Haven't seen him since, and we signed him up for gel injections today. So it could be. It's really trial and error, and we can't predict the future. So I would still stick with those injections for your wife and see how she does. Is it common to need a hip replacement for a labral tear that can't be surgically repaired? Yeah, it's becoming more common. And what we're finding is that patients in their 50s and 60s who undergo what's called arthroscopic surgery for hip problems, like a labral tear, tend to not do as well as patients under the age of 40. And so it is becoming more common that, if patients have degenerative hip joints that maybe aren't severe in nature from an arthritic standpoint, but have other problems, that a hip replacement might be the option. Need both hip replates, 100% bone on bone, trying to lose weight to be able to have both done at the same time. What are the pros and cons of having one done, recovering with a bad hip versus having both? I think really the big issue there for you is that having both done at the same time does incur a significant amount of blood loss. And so I tell people, look, just do one at a time. Most people can recover just fine with one bad hip and one replaced post-operative hip. But my big concern would be blood loss in the time of surgery. Please stop screen sharing. I don't, yeah, okay. I don't know if am I screen sharing? Let me check. Oh, stop share. There we go. Sorry about that. Yep, I was screen sharing. Is arthroscopic knee joint clean out a realistic possibility? It depends on how bad your arthritis is. And what your problem is. So if you have a meniscus tear and you have good cartilage, then an arthroscopic surgery is a great idea. But if you have a bunch of cartilage damage and you're going in there to try to clean that up, arthroscopic knee surgery typically doesn't work very well. We have a lot of studies and guidelines even that state that arthroscopic surgery isn't indicated for an arthritic knee. I had pain in the knee and the butt. The knee pain was treated with cortisone. Can one pain cause the other? That's a tough one. Certainly things can be connected, like the hip bone's connected to the knee bone, connected to the foot bone. But yeah, I mean, things can be related. Sometimes pain can radiate from the hip down to the knee. Typically, they don't tend to go the other way. But certainly the two issues could be connected, or you could have two problems. You could have an arthritic hip and an arthritic knee, or even a degenerative back as well. We got that question already. What's the typical recovery time for a meniscus root repair? I didn't talk about that because that's not really what I do, but the meniscus is a shock absorber in the knee. And it's when your meniscus is torn or when it gets removed, it actually predisposes you for arthritis. So it's really helpful if you can, if you have a meniscus injury, to kind of save it by repairing it instead of just cutting it out. A meniscus root repair is a not too common of an issue, but when it happens, it can be helpful for a patient if they don't have arthritis to repair that meniscus because that can prevent the development or delay the development of arthritis. So recovery times may vary based on your surgeon's protocol, but usually it's at least 8 weeks of either non or partial weight bearing or limited bending. Do you use robotic surgery? I use robotic assistance in some of my procedures. I use artificial intelligence in some of my procedures. And some of them I just do just traditional manual surgery. They all work. There's really no difference in outcomes in any of them. 50 years old, and I have bone spurs between my femur and patella. I was told it's best to continue with injections for a few years. Is this reasonable? It certainly is. The younger you are, the tougher it is sometimes to recover from these surgeries. But as long as the injections are working, it's reasonable to continue with them. But if they're not working, then maybe you're better off considering a surgery. And I recognize the name, so call me if you need something. Encouraged by the words minimally invasive laparoscopic surgery in the description for this presentation. Does that apply here? If that was the description for the presentation, we don't do a laparoscopic joint replacement. I don't know of anyone who does. Then we would need to fix that. But no, that laparoscopic surgery does not apply to hip and knee replacement. Where are the outpatient surgeries performed? We're affiliated with a number of surgery centers and hospitals. So they're performed really all over the greater Philadelphia and New Jersey, South Jersey region. Baker cysts behind the knees can be a challenging thing. Oftentimes they form because there's a problem in the knee joint itself. And so correcting that problem, whether it be a meniscus tear, whether it be cartilage damage, whether it be arthritis, typically can help to improve a Baker cyst. I can tell you like a Baker cyst, to remove the fluid from it or drain it, usually it comes back. So it's more important to correct the problem causing the fluid to leak out of the knee joint. Can a knee replacement be done robotic? Yes, we do robotic assisted joint replacement at Rothman for hips and knees. The robot doesn't do the surgery. It's just a tool the surgeon uses to prepare the bone and place the implants. So it's a bit of a misnomer in that, a robot is not actually doing it. If you're allergic to metals, what do you use in the surgery? Well, for hip replacement, those are pretty much all titanium, excuse me. So there usually isn't an issue with allergies. For knee replacement, you can use like a ceramic coated knee. And there's a couple of brands of knee replacement that have those. So if you're allergic to metals or cheap jewelry, that's a good thing to tell your surgeon. I live in an apartment that has 13 steps. Congratulations, you can get a hip or knee replacement. I always tell people you're going up and down the steps now, probably one at a time, and you'll do the same after the surgery until you kind of get stronger to kind of get to a more normal gait. How does a torn meniscus come into play with arthritis? Meniscus can't be repaired, so can you still have the surgery? Yeah, when you have arthritis and a torn meniscus, typically the meniscus will take a back seat and you really just treat the arthritis. The conservative treatments tend to be the same: physical therapy, injections, anti-inflammatories. The problem with doing a knee arthroscopy on a person with a torn meniscus and arthritis is even if you fix the meniscus problem, they still have the arthritis problem. So they could still need another surgery 6 months, a year, 2 years down the road. And we want to try to avoid doing multiple surgeries if we can. My doctor describes my knee arthritis as moderate. He says he can't get his tool into the available space for a cleanout. Is that realistic? Yes, it is. If you have moderate arthritis, the data and evidence suggests you should not have an arthroscopic surgery. And you should probably consider more, conservative treatments for knee replacement. At some point, if those fail, a knee replacement may be appropriate. I've used aloe vera for preoperatively for pain management and increased ability to participate in PT. Oh, have you used? Aloe vera is, someone asked a question about ablation therapy, and aloe vera is a way to decrease pain by essentially a nerve block. I have not used that in surgery because I don't have anyone that does that procedure routinely for me. I've heard good things from a surgeon down in New Orleans. Haven't seen great data on it. I'm limping. Should I be walking daily? Yes, you should always be walking daily. If you're limping, it may be a good idea to get into physical therapy and hopefully improve your gait that way. I fell going up marble steps in February and hit my knee. Could arthritis develop from a trauma like that? Probably not. When we talk about post-traumatic arthritis, we're usually talking about fractures that go to the joint, like a tibial plateau fracture or a distal femur fracture. So you probably wouldn't develop arthritis from that. What sometimes happen though is people have pre-existing arthritis, don't know about it. And a mild trauma or a mild fall or twist might kind of exacerbate it and turn it on. And then that can be challenging to kind of alleviate those symptoms and control it. Acupuncture is a great alternative to surgery. If it works and gives pain relief, perfect. At some point, it tends to not work. I've had plenty of patients try it and have some success with it though. Can you have knee replacement if you're still functioning in your 70s rather than 80s? Sure. 70s or 80s are a great time to do knee replacement. Why would, after getting gel injections with the knee, get worse? It could just get worse if the gel shots don't work for you. They're not 100%. It's kind of a trial and error. So if your pathology and your disease is just getting worse, the gel shots may not fix everything. 13 steps to go up steps. Yeah, you could do that the first day, or you could sleep on the couch the first day, whatever you're comfortable with. I think the key there for you would be to go to physical therapy before surgery to understand how you're going to combat that and how you're going to tackle that issue. Can bursitis of the hip turn into arthritis? No, it can't. Bursitis is a common condition people can get most commonly in their shoulders, hips, knees, and elbows, typically treated with anti-inflammatories, therapy, and injection. If those fail, and they usually don't, surgeries are an option, but very different from a hip replacement. Ideal BMI for a knee replacement, I think somewhere between 25 and 35 is probably ideal. Believe it or not, people who have really low BMIs, like 15, 19, they're actually also at higher risk for complications. So there's sort of a sweet spot, probably between 20 and 40 or 25 and 35, something like that. I have a tear in my right meniscus and moderate arthritis. Was told the tear was in white matter and not repairable. That is a thing. Menisci get blood supply from the outside part of the joint. So there's a red area where they're getting good blood supply, a white red area that's kind of okay blood supply, and a white area which has poor blood supply, so poor potential for healing. So that's very possible that it's not repairable. Had an MRI due to a knee injury playing sports. Doctor said I'll need a knee replacement down the road. How do you recommend I extend the number of years before needing surgery? I'm 57 and not overweight. Yeah, that's half the battle. Keep your weight under control and stay active with an exercise and strengthening program. And that's going to be your best way to prevent a knee replacement. If you have rheumatoid arthritis, there's the autoimmune disease for, wait, no, the autoimmune disease typically doesn't attack the implant for rheumatoid patients. So our rheumatoid patients are some of our longest lasting joint replacements. So you have the potential to do great. Does infrared therapy help with pain? There's some therapy, there's some literature and data out there that it can. Certainly something to try. Probably not a first line treatment, but it is, if you're going to exhaust all of your options before surgery, then it's a great option. This patient has bone on bone arthritis in the left knee. Dr. Schnell has seen this patient. Dr. Schnell is great. He's my partner, so you're in good hands with him. These were great questions. I know Kristen mentioned we did have to stop.
I'm very
So I think,
impressed you got through all of those.
oh, good. Wow, great.
Yeah.
If anybody has more questions, please send them to Kristen. We have multiple offices throughout the greater Philadelphia region, and so we would love to see you at any of our offices. And I think here's our office phone number, a VIP line, and Kristen has all that information for you too.
Yep. And you all
Kristen,
have my email and my phone number. So if you have any questions or if you'd like to schedule an appointment, you can reach out to me and I can have our scheduling team contact you so you don't have to even make the phone call.
that's great. Thanks so much for doing that, Christian. Everyone, thanks so much for being here. A great crowd. At one point, I saw like 150 people. So
Yeah,
hopefully, people
great.
got some good information and can use that to kind of get more out of their office visit when they come see us.
Sounds great. Thank you so much,
All right.
Dr. Saxena.
Take
Thank
care,
you,
guys.
everybody. Have a
Thanks,
great
Kristen.
night.